Welcome everyone to Mayo Clinic Q&A. I'm Dr. Halena Gazelka. Opioid abuse and overdose has been an issue that has plagued the United States and every part of the world, frankly, for the past decades. Before COVID-19 captured our attention, a concerted effort was underway to combat the opioid epidemic. Unfortunately, during the time of the COVID pandemic, overdose deaths have accelerated and increased dramatically in many areas. However, there is an antidote. Naloxone is a potentially life-saving medication that can be administered to those who overdose. It can be given in any setting. And here to discuss this with us today is Dr. Bonnie Milas, a professor of clinical anesthesiology and critical care at the Perelman School of Medicine at the University of Pennsylvania. Thanks for joining us today, Dr. Milas.
Thank you. Thank you for inviting me.
It is such a pleasure to have you here. So many times we have experts from within Mayo Clinic, and it's just a joy to have you here. I have heard you speak and was so impressed, and I knew that our listeners would want to hear from you too.
Thanks again.
Bonnie, I'm wondering if you would mind starting by just telling us a little bit about your story.
Sure. As you've already mentioned, I am an anesthesiologist, so I routinely handle large doses of intravenous opioids. Unfortunately and tragically, I have lost both of my adult sons to accidental opioid overdoses. I am deeply committed to reducing stigma surrounding opioid use disorders and also in saving lives. As anesthesiologists, we are very keen to identify opioid overdoses. We are facile at administering Narcan, and we are also experts at airway maneuvers and rescuing people. I have been spearheading a campaign with my professional society, which is the American Society of Anesthesiologists, and this is a grassroots movement in order to get our members to not only carry Narcan, but also to go out in the public and teach community members how to rescue opioid overdose victims. Now, certainly I'm a physician, and part of what I will be talking about comes from a medical knowledge base, but I will also be adding in my personal story because of the experiences that I have had. So they come from deep personal, really, involvement and experience.
Well, thank you, Bonnie, for being so candid with our listeners and sharing your story today. That's really meaningful. As a pain physician, it's difficult for me at times to tease out whether a patient might have issues with addiction. It's often a very private or sensitive topic. People are sometimes secretive about their use. Sure. Are there typical signs and symptoms that individuals should look for to know whether a friend or a family member might be suffering?
Certainly most, if not all, addictions start in secrecy. People are ashamed of what they're doing. Our boys did not come to us saying, "Hey, I'm struggling." And it really only came to light once we started noticing behaviors and also looking for things in their immediate environment, like their bedroom or their backpack or their briefcase. So when it first starts off, this is usually with pills. So it's really hard to detect. But once it got to the point where it was affecting their ability to even stay awake, and what we would notice would be a particular behavior of what is called dipping out or nodding off. So this would be falling asleep when they really shouldn't be falling asleep. This would be when they would be standing upright or when they would be engaged in a behavior like eating dinner, but they would lose consciousness or slowly fall asleep. And along with that, they would have kind of a noisy, slow breathing pattern.
How frightening for you as a mother.
Yeah, and also once it gets to the point where they're switching over from pills to the point where they're using intravenous drugs, then you start to find things in their vicinity, like you might not find the whole syringe, the really thin tuberculin syringes, but what you would find is an odd shaped orange cap that belonged to the syringe. Might be laying on the floor, or you would find they're called glassine bags. They're very small, like postage stamp sized wax paper bags that have the heroin inside of the little bag. But I might find those, and they would have a little ink stamp on them from the dealer that they purchased from, that I would find those papers either in the waste can or on the floor. Also, very curious, these little tiny, like 1-inch elastic bands or rubber bands, and oftentimes in bright colors, that would be used to bundle, say 10 bags of heroin together. So it's those types of things. You'd find odd things that you didn't really know what they were for. And it wasn't as if my boys were using them for hair ties. It was just a curious little finding. But I think if you knew to look for those things, that you would be able to pick up on use a little bit earlier, and you would follow up on it.
And Bonnie, I think that most people would understand that there is a trajectory or a time between going from pills that people obtain to using heroin. But I'm wondering, when you talk about using pills, are you referring to actual prescription drugs like oxycodone?
Sure. So it would be pills that either were purchased or given to them at school, but they were certainly pills that individual either got from their parents' supply, or that could be purchased easily on the street. But yes, it would be prescription medications that were otherwise being used indiscriminately.
And I'm wondering if you could tell us a little bit about the science of opioid use disorder to help us understand why it is that someone transitions between using pills that they're obtaining from someone to using stronger medications, because the opioid medications are not all made the same. Certainly heroin is a more potent substance than is oxycodone, for instance. What is it about the brain and the body that causes people to accelerate their use?
So once an individual is used to seeing a particular substance, they develop what's called a dependence. So in order to get that reward or that sense of endorphin release of that feel-good experience, that they oftentimes have to increase the amount of drug that is taken in order to feel that. And when they don't have that in their system, then they start to go through what's called withdrawal. And withdrawal is the drug sickness that comes when you don't have that in your system. So it would be symptoms like actual pain, muscle aches, body aches, nervousness, jitteriness, tremulousness, nausea, vomiting, diarrhea, goose flesh. And it's those withdrawal symptoms that individuals will try to avoid because they're so distressing to them. So they will continue to use, and it's a drive just can't compete with. So they will continue to use and higher amounts of drug. But that also sets up the problem of the expense of ongoing drug use. So whether they're trying to purchase pills or whether they're trying to buy heroin, that they need money. So that leads oftentimes to negative behaviors. So they become very manipulative. They start lying, hiding things, stealing. And in fact, it can lead to really criminal behavior. But certainly it really destroys and breaks down their relationship with family members and friends. Very, very destructive, negative behaviors. And that's really the basis for where stigma comes from, because this is an individual that is engaged in those type of very negative behaviors.
Yeah, I've been very interested, Bonnie, in that you mentioned the stigma of opioid use disorder because I heard someone give a talk once and describe that addiction is not something that people go out to seek. When they first take their first oxycodone to get a high off of it, they're not thinking that they're going to become addicted. And addiction is a miserable state to be in, that eventually people are using drugs just to try to get to the level we are at most of the time. They no longer get a high off of it. And I
Right.
found that to be really interesting in a way to think compassionately about patients with addiction.
Sure. Well, not only that, but when you think about, in particular, say, an adolescent who, whether they are prescribed a medication and they start to use it inappropriately, or whether, again, it's pills that are offered to them by a friend, that they start to expose themselves. And for some of us, although we're all at risk for addiction, some of us can take those medications and not have really much of an effect other than it treats pain. But for other people, they take a couple exposures and it's like brain is like lit up like fireworks, and it sets up a craving that they have such a desire, just such a powerful drive to fulfill that they continue on and continue to seek that experience. And it's particularly dangerous when you're talking about a young developing brain, because then it sets up neural pathways that are just reinforced, and it is very, very difficult to stop once you get on that pathway. So whether that individual started in a means to experiment or to try something, that it becomes it can become a lifetime pattern that is nearly impossible for them to interrupt. Whether they took that to feel emotionally better or to quell something, some disquieted feeling, that again, it can progress to just a lifetime of drug use, which they never intended.
Bonnie, I'm a little bit familiar with teenage drug use. My daughter is a young adult now, but she told me after she graduated from high school about some of the parties that she had gone to where drugs were freely available and distributed, even here in Rochester, Minnesota. But sometimes our young adults, we are given opioid medications legitimately. So maybe a teenager goes in and has their wisdom teeth out, or has a sports injury and they're given opioids. What kind of precaution should parents take to help reduce the risk that their child would either develop a dependency or share those medications with others?
So I would say the first question that I would ask if my minor, my child or adolescent is going to be prescribed an opioid, I would ask the practitioner, what else is available, especially if this is minor pain? Can my child take NSAIDs or non-steroidal anti-inflammatories like Tylenol or Motrin? Are there any adjunct therapies that can be used, like a topical cream, an anesthetic cream that could be used? Certainly, if this is major pain, bone pain, or if it involves major surgery, then oftentimes an opioid is the right choice for a brief period of time. So I would talk to the practitioner about limiting the dose and limiting the number of pills that are prescribed. In addition, I would say it's probably best practice for the parent to keep control of that drug supply in a secure location, know how many pills were prescribed, and again, have them securely located. Depending on your child and their age and their risk behaviors that they may have displayed in the past, I would consider watching them consume or ingest the medication as well, because then you're absolutely sure that that medication is being used appropriately and you know exactly where it went. Um, and then finally, once the prescription, if you haven't used all of the medication in the bottle, there are plenty of take back programs out in the community whereby you can turn in any leftover medication. So it eliminates the risk really of it being misused.
We've put some bins in our pharmacy here actually to collect
Yep.
opioids within the last several years while we've been doing this work.
Right.
You know, we've been talking about adolescents and young adults, but frankly, even older adults are at risk of
Certainly.
developing opioid use disorder or developing chronic long-term use of opioids.
Yeah.
So I even tell my adult patients that the risk is higher, the higher number of pills that you use, the longer that you use them after an event such as a surgery, the more refills that you get. So frankly, using the lowest dose for the shortest time possible is some pretty sage advice. Can you tell us about your community outreach work, Bonnie? I know that you do quite a bit of this about teaching individuals how they can respond to an opioid overdose. Who is at most risk of suffering from an opioid overdose?
Sure. Certainly, any individual with an opioid use disorder history is obviously at risk. But in particular, if they are using overnight or they're using alone, that puts them at increased risk. If they go out and they seek a drug from a new supplier, that also is a potentially unreliable source for them and puts them at risk. If that individual with the use disorder is recently being discharged from a recovery program, or if they're being released from jail, they may still have that underlying craving to use. And the first time they go back and use, they use the exact same amount that they used before going into the program or incarceration. So their tolerance is very low. They use the same amount and they immediately overdose. That is a common scenario. As soon as they walk out the door, you know, God forbid they use and they're overdosing. I would also expand that list of at-risk people to just like what you had mentioned is I would consider any home that has an opioid prescription available in it is at risk, and that you should consider having Narcan in your home. Over 50% of overdoses occur in the home. The remaining happen in public spaces. So, you know, your drug supply, your medication, your vanity has pain pills in it, which may be discovered by or left out and discovered by a toddler or by a teenager who is wanting to try and is experimenting. And you already mentioned an elderly individual who is now getting forgetful, can't remember that they took their medication already. So they would be at risk accidentally of having a toxic adverse event and overdosing. So I think that what I described is a very large group of people who are at risk, and this could be in your home environment. So that goes back to the importance of having Narcan or Naloxone available and having a basic set of skills.
Those are really good points that you make, Bonnie. I always tell my patients that there are people probably who are at higher risk of addiction, but we don't know who they are yet because we don't have the genetics of that worked out yet.
True.
I'm wondering if you know, when using this word overdose, what happens when someone overdoses and what causes them to die?
Yeah. When we're talking about overdose, you have to think about opioids are very powerful central nervous system depressants. So they depress the brain. They cause an individual, if all of their receptor sites are occupied by the opioid, it causes them to lose consciousness, causes them to fall asleep. You cannot wake them up. The opioids also work on the respiratory or the breathing center in the brain. So breathing slows and then stops. This is what we would call a respiratory arrest. They stop breathing. And if this is allowed to continue without any interaction or intervening by a family member or a health professional, that the brain is also not getting oxygen, cell injury is happening, it's starting to occur in the brain, there's no oxygen being delivered to the heartbeat slows, and eventually heartbeat stops. So now they're in cardiac arrest. So I think the take-home message for our audience is to understand that the sooner you intervene in that whole time sequence, the better outcome for the individual. So it's best to, obviously, to discover them unconscious, slow breathing, and you intervene at that point. That's how we can best save lives and mitigate injury due to opioid overdose.
You mentioned receptors, and just as a point of clarification for our listeners,
Sure.
I'll maybe explain that the pain medicines, the opioids, or the illegally produced drugs that act like them on the central nervous system, the receptors for those are spots in the spinal cord in the brain where that drug attaches and then has an opportunity to cause its effect on the body.
Right, and in fact, that's how naloxone or Narcan, that's how it works.
That was going to be my next question for
Yes.
you. Let's talk about naloxone. What is it and how does it work?
Right. So as you mentioned, we have little landing zones or little receptor sites in the brain, and that's where the opioids land. They occupy them, and that's how they exert their effect. Naloxone or Narcan, it works by displacing or kicking off the opioid from that receptor site. So it has the ability to interrupt the process, to allow the individual to start breathing, restore respiration, and also to allow them to awaken and become responsive. And that's how the drug works. And in fact, naloxone, there's no other use for that drug. And in fact, if you end up giving naloxone to somebody who's not overdosing, that it has no effect whatsoever. So you can't hurt someone by giving naloxone when they're not overdosing. It takes about 2 to 3 minutes, the nasal form, to restore breathing and to awaken them. And now with fentanyl or fentanyl analogs available on the street or contaminating our drug supply, that these are very, very powerful. And it may take more than one dose in order to reverse an overdose. So it may take 2, 3, 4 doses to reverse what we just talked about. And then in the meantime, again, you still have to wait the 2 to 3 minutes between the doses. But during that time, if they're not breathing, then that's when rescue maneuvers need to be put into place. While you're waiting, you've already called 911 and you're waiting for trained help to arrive. What can you do in the meantime?
Bonnie, before I ask you to sort of describe how one uses naloxone, I just want to clarify that fentanyl is a very potent or strong opioid medicine that you and I use commonly in
Right.
anesthetic practice. So it's a very rapidly acting medicine that's administered by IV. It's really an ideal drug for doing procedures, for sedating patients for procedures, or helping patients who are in very acute or extreme pain in the hospital or the surgical setting. But on the street, it's a very dangerous drug, and it's being produced illegally in many countries, and it finds its way into the United States and often contaminates the drug supply of other drugs, such as heroin. Correct?
You're right. So you're bringing up a good point. There are medical uses for fentanyl. We're talking about the non-pharmaceutical drugs that are, again, coming in to the United States and contaminating the drug supply that's available on the street. Mm-hmm.
So Bonnie, you mentioned that it would be wise for anyone who has opioid pain medications in their home to have naloxone in their home. What is it that they'd be having in their home, and how are they going to use it?
Say that again, your question.
So you mentioned the drug naloxone, and that patients who have a prescription for opioids in their home should also consider having the drug naloxone in their home. And I'm wondering if you could describe how that drug is supplied by the pharmacy and how one uses it in an emergency.
So it is available at any pharmacy in the United States. You can walk in and you can ask for it by name, and the drug will be supplied to you. And otherwise, it's typically either in the nasal spray form like this, or it comes as a syringe with a small nasal adapter. And it is simply a matter of just putting this little nasal trumpet into the nose and then pressing, and then there's a spray that is released. So it is just as simple as a nasal spray. Same thing with this device. You just attach it. There's a screw-in push device, and it delivers the nasal spray. So that is how it is used. So you do not need to be a physician. You don't need to be a healthcare professional or an EMT in order to rescue an individual.
Some of our listeners are listening rather than seeing this on video, but like you described, it's similar to using an over-the-counter nasal spray like Afrin or something else you might put into your own nares.
Right up the nose. It's not any more complicated than that. It is a nasal spray. It's simple.
How would someone know if they needed to give someone naloxone?
Well, what we've already talked about is if you were to find someone who is looks like they are collapsed or sleeping, and you are concerned. So you would go over to them, whether this is a family member or whether this is somebody that you see in public, and you try to awaken them, and you can't. And it's a vigorous shoulder rub, and you could ask if there's somebody around them, whether or not this person has a substance use history. If they're alone, you may find some of the items that I've already mentioned, whether it's a syringe or a package, but you have some suspicion that you cannot awaken them. They're breathing. If you put your hand on their back or on their chest, their breathing is very shallow or has stopped, that you would first call 911, ask for help in your immediate environment, and then if you have Narcan on you, you would just take general precautions, either by putting on gloves, you may already still be wearing a mask, and then to administer the nasal spray. In general, we recommend that you turn them on their side or into what we would call the recovery position, just in case they were to vomit. You don't want them to get any material down into the lungs, but that you put them in a comfortable side-laying position with their head slightly elevated. That would be the usual response for an opioid overdose.
Well, thank you, Bonnie. You know, this opioid crisis has been going on for so long now, and it seems to be so multifaceted, involving the supply of drugs, individuals with opioid use disorder, even providers who legitimately want to help patients who have pain. And I'm wondering, do you see solutions to the opioid crisis in the future? Do you think it's ever going to get better?
I certainly do expect that we are going to pull through this. This is a major societal problem, and I think, as you already mentioned, this has been developing over years. So it's not going to be a quick overnight fix. But I see this as being, again, a societal epidemic that needs widespread changes in how we address it. First and foremost, as we are talking about, we need to save lives. The overdose death rate has increased over the past year. and it's alarming. What's going to happen after that? But we need to save lives. So again, we're talking about having naloxone immediately available, not only in the home, but also in public spaces, and having also some basic rescue skills right at your fingertips. Additionally, we need to keep, we've already mentioned, we need to keep fentanyl out of our public, non-pharmaceutical, illicit drug supply. We need to keep it from entering the United States. Also, we are already making great strides in making sure that pills are not being redirected inappropriately. So if we decrease the number of pills available in the general population, we make sure that they know how dangerous it is to have them unsecured. That will also decrease the entry point, which we already mentioned. That's how most people get into drug use, is by pills. So if you limit that, you help prevent the entry point into addiction. Treatment should be readily available. And I would suggest that if this is somebody who is using oral medications and they cannot stop, they've either overdosed or they've already moved on to IV drug use, that treatment should be 90 days, inpatient treatment, something very aggressive at the beginning stages of their very serious use. And I would also advocate for long-term care after that, and it has to be in a supervised situation, something that is 6 months or maybe 12 months to address it hardcore, to really help that individual for long-term sobriety. Final thing is we need to combat stigma, because stigma does nothing but discourage individuals and families from receiving the treatment that they need.
I think one of the very important things is what we're doing here today, Bonnie, where you and I are sharing information. I think people hear and see articles and news about opioids and their dangers, but don't really understand the problem. I have many patients that I have to convince to use pain medicines when they really do need them, because they serve a very legitimate purpose for individuals, and they're very important medications for us to have legally available for people.
Yep.
But I think that this information is great, so I really appreciate you sharing today.
Well, I would say, stigma, out of the list of solutions to the opioid epidemic, stigma is the hardest, I think, to really combat. And again, I already mentioned that it prevents engagement with real treatment. And this is very deeply rooted in our society, that people have the concept that, well, you willingly took something, and therefore, well, why don't you just stop doing it? Mm-hmm. So that concept, because of what we know about dependency and withdrawal, that is rarely easily achieved by willpower. That willpower has nothing to do with it at that point, once the dependency sets in. And also all of the negative behaviors that I already mentioned, that manipulative, stealthy, behavior in the individual who is suffering, that alienates them and destroys relationships with other people. But you're right, somebody like myself who has personal experience with this, coming forward and sharing my experience, my story, that it helps to humanize this. It puts a face to it. Our family has gone through this, and by sharing, it helps other families to know that I know what you're going through, and we need to come forward as a nation and be able to talk about it a bit more openly, and to be able to share that part of what we've been through.
Bonnie, I would imagine that as a physician and as a mother and as a friend to other people, there's some fear in having to admit that this is going on in your own family and that you're struggling. And I'm wondering, who did you rely upon to both share that information with and to receive help from when your family was struggling?
So for our family, and you have to keep in mind that this was mid 2000s. So the opioid epidemic was not something that was splashed on the newspapers yet. It wasn't really, in the news media. So when it had its roots and it was in its infancy, so to speak, that the only people that we were really talking to were behavioral health specialists. So those were the only people outside of our immediate family, outside of our home. No one else knew what we were going through. And otherwise, I would say it was our boys, it was their personal behavioral health. So it wasn't really my story or my husband's story to tell. It was whether they were ready to share it. And I would say that society really wasn't ready for that type of open discussion, particularly in our suburban neighborhood.
It must have been very isolating and difficult. I can only imagine.
Certainly. And it still is. It still is. I
Sure.
think we're getting better, again, with people coming forward and talking about what they've been through.
And how courageous that you have done that, Bonnie. We can't thank you enough for sharing your story today so that others can learn from it.
Again, I'm happy to be here. I'm glad that the Mayo Clinic is taking it upon themselves to make this an important issue and to make sure that their patients and those that they treat have open access to the information and to this type of conversation. Certainly.
Bonnie, if there are people listening today who wish that they knew something that they could do to help amplify these messages, what would you recommend?
I would ask that the listener be mindful of the amount of suffering that goes on with the individual and also with their families. I don't know how many in the audience have, like myself, who have stumbled on my son's body and found him lips blue, not breathing, unresponsive. And I had to do and gladly do full-on CPR and revive him. And that's coming from a medical professional. So, as upsetting and stressful as that is for somebody like myself, and I do this, on a routine basis. That's what I do for a living. Just imagine you're in that situation. You don't have Narcan, you don't have the skills, and it takes the average time for EMS to arrive at your home in the United States is about 7.5 minutes. It varies depending on where you're located. But when you are standing there, that is a profoundly stressful thing for any individual to undergo. So again, for audience members, this is a great deal of pain, a great deal of suffering. That this is a medical condition. It deserves the same amount of attention and research dollars that any medical condition does, such as heart disease, heart attacks, diabetes, lung cancer. This is a societal cancer right now that really requires dramatic intervention. I would also probably ask that audience members be kind with their language when referring to individuals that suffer from this disorder. And then finally, to kind of bring everything to a close is for audience members to really consider having naloxone or Narcan available in their home, to have the skill set available to respond appropriately. I think that certainly not only the opioid epidemic, but just with COVID-19 and social events that have happened over the course of this past year, we've all had our social conscience raised, okay? Now, you might say, well, my family has not been affected by this. But, okay, so maybe not your family. Maybe you don't need that in the home. But consider that you go out to your car, you're in the parking lot, and somebody has overdosed in their car, okay? Or you stumble upon somebody in the restroom at Starbucks. Well, you've called 911 and there you are, okay? You've heard this message and you know that you can go out and have Narcan available in your briefcase, have it on you or in your car. And in the meantime, while you're waiting for trained help to respond, that you are in the role of being an immediate responder. You can recognize an overdose, you can give Narcan, and you can save someone else's mother, their brother, their child. That this is really a means of being socially responsible. And I would encourage audience members to consider these words.
Bonnie, as a mother, I simply can't imagine anything more horrifying than what you described. But I hope that even if one listener today recognizes themselves or a family member in the discussion that we've had, that they will heed the message that you've given today. Thank you so much for being here with us and sharing.
You're welcome. Again, I applaud Mayo for your efforts.
Thank you so much, Bonnie.
You're welcome.
You've been a wonderful example to us.
Thank you.
Our thanks to Dr. Bonnie Milas, Professor of Clinical Anesthesiology and Critical Care at the Perelman School of Medicine at the University of Pennsylvania. She spoke with us today about naloxone saving lives. I hope that you learned something. I know that I did. We wish you a wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on podcasts. Thanks for listening and be well.